So diabetic eye diseases are a group of conditions which affect the people with diabetes. The main conditions are cataract, glaucoma, and diabetic retinopathy. In fact, diabetic retinopathy remains the most common complication of diabetes and is the leading cause of visual loss in working age group and may potentially cause blindness. We need to know why diabetic retinopathy affects the eyesight. There are two mechanisms. Firstly, there's leakage of fluid in the central retina, which is also called macula, and this condition is called diabetic maculopathy. We can apply focal or grid argon laser in this condition. The other condition is called proliferative or advanced diabetic retinopathy. When the back of the eye is starved of blood or oxygen, the retina may respond by growing abnormal blood vessels, like in this picture. These new blood vessels can bleed into the jelly of the eye, within the eye called vitreous hemorrhage. It causes a sudden loss of vision that sometimes needs surgery to resolve. Rarely, these abnormal blood vessels cause a painful high pressure within the eye called neovascular glaucoma. The treatment for proliferative diabetic retinopathy is urgently advised to protect the eyesight. The prompt treatment can reduce the risk of further vision loss and a blind, painful eye. Treatment of these abnormal blood vessels can be with anti-VEGF injections or with laser, pan-retinal photocoagulation. Anti-VEGF injections work quickly but need careful long-term monitoring and often repeat courses of injections. Pan-retinal photocoagulation or laser scatter photocoagulation is more likely to give long-term protection with needing just 1 or 2 treatment sessions. When we talk about laser treatment to the eyes, they are compatible because we have a small structure which needs focused treatment. And for that, we need to look at what the retina or the photographic film of the eye is. The central part is called macula. And then we have the peripheral retina just beyond this yellow ring. Central retina is important for reading, face recognition, and color vision. The peripheral retina has the function of providing sight vision, night vision, and eccentric viewing. Both have their roles, but it is very essential to protect the central retina or the macula. So the lasers used in maculopathy or for the treatment of central retina, they are very small burns on a very focused area where the blood vessels are leaking. They take up to 3 months to show their full effect. And then when we have abnormal blood vessels growing, called proliferative diabetic retinopathy, we need to apply the laser to the periphery of the retina or scatter laser to protect the central vision. It is done in a very judicial way. Usually 1 or 2 sessions are enough to ablate most of the peripheral retina. And you can see we have tried to protect the central retina, but the laser has been applied to the periphery of the retina. Basically, there is mismatch between the oxygen and blood supply, and by ablating the less useful vision, we protect the more essential part of the vision. And this complex decision is made by the treating ophthalmologist. They can combine laser with anti-VEGF injections, which have been very effective, but they need repeating and after a time may lose their efficacy. Essentially, pan-retinal photocoagulation has been the mainstay of treatment for proliferative diabetic retinopathy over more than 4 decades now. With precise lasers, smaller machines, and focused areas of treatment, patient can maintain their eyesight for a long period of time. So coming to the risks, when the peripheral vision is compromised by causing scarring of the retina, there may be difficulty with night driving. People may have impaired driving ability and they are advised about it before we start the laser treatment. An informed consent is obtained and the treatment is done judicially, protecting the vision to the standards of driving for a particular person. Sometimes there is spillover in the center if too much of laser is applied, causing some macular edema, which can affect the color vision and reading ability. But again, it can be managed with anti-VEGF injections or sometimes with precise laser to the very center of the retina. Patients may get a bit of discomfort because the laser can hit the nerves in the retina. But we can titrate and adjust the laser parameters in consultation with the patients at that particular time. In this image, you can see the laser has been applied with what we call multi-spot laser, very quick, less discomforting, and the central macula is spared in both the cases. And there are some old scars because we can repeat it if it is necessary in the future. So definitely pan-retinal photocoagulation with argon laser has role in proliferative diabetic retinopathy. The effects are mostly transient and the benefit is long-term. Lasers have been useful for both proliferative diabetic retinopathy, applying pan-retinal photocoagulation, which still remains the mainstay of treatment all over the world. We have newer machines which can apply laser to the central area with what we call micropulse laser, because the effect of laser is that when the spot is applied, it can spread. But with the multi-spot or micropulse laser, actually the spot size decreases with time. And this is another type of focal laser called Nevilas. It is targeted, it incorporates images with the OCT scan and targets the area which needs to be treated. So with time, machines have become more predictable, results are better, and combination therapy is what we need to apply to the patients. Sometimes there is lack of blood supply in the very center of the macula called ischemic maculopathy, for which laser is not advisable, but anti-VEGF injections can still reduce the fluid in these conditions. And looking at the macula itself, if it is right in the center, we would prefer doing the anti-VEGF injections, but again, it is a patient choice we discuss. But it is slightly off-center, laser of smaller size, less intensity and duration will have long-term impact as compared to anti-VEGF injections. And one thing I mentioned earlier was if there are a lot of blood vessels growing at the back of the eye, they can affect the eye pressure, and there can be very acute rise. In that situation, we apply further pan-retinal photocoagulation if it has been inadequate to manage the acute condition of neovascular glaucoma, which is a not easy condition to treat. When we are doing the laser treatment, either focal, grid, or pan-retinal photocoagulation, we dilate the pupils with special eye drops. So it is to help us look at the back of the eye and target where the laser beam will be applied. So it may take 2 to 4 hours for the vision to come back to normalcy. It is always advisable for people who are coming for laser treatment not to drive afterwards. Then the light intensity is quite bright. People may feel startled initially, but they settle down. If there's a pain during the procedure, we can change the intensity and duration of the laser beam to the extent that they can tolerate it better. Sometimes we have younger people or people have low threshold. We can do the treatment with what we call indirect laser, which is head mounted, and we focus on the retina. And sometimes we take them to the theaters, numb their eyes with anesthetic around the eyeball so that the quicker laser can be applied to these patients. Still further, if patients have advanced diabetic retinopathy, they may need vitrectomy to remove the jello within the eye, and at the same time we apply laser to the retina. This is called endo laser. That means all the procedure is done in one go, moving the blood, stabilizing the retina, and applying the laser so that it has good impact and is eventually time saving for everybody. Patients can go back home within 30 minutes of the laser treatment. Diabetic macular edema takes up to 12 weeks to start showing resolution, and it can be repeated if it is not right in the center. For pan-retinal photocoagulation, patients are usually comfortable when the pupil comes back to its normal shape. They can drive when they are comfortable and feel that they can see the number of plates at a specific distance as defined by DVLA.